Hello, this is welcome to the next episode of this blood sampling in newborn. This is part 3, the ways and means and the ifs and buts of blood sampling in newborn. You have listened to the earlier two presentations, so the important significance of sampling, the blood volume in the tiny dots, the sub 500 babies. And then we have discussed about the need for autoanalysis, the miniaturization in this nanotechnology robotic world. Then we discussed the ways and means of sampling, which was the capillary blood sampling or microsampling, and how to make it even automated and ensure safety without any risk to the patient and to yourself. That was the previous presentation, part 2, capillary blood sampling. I come to part 3 here, peripheral vessel sampling from upwards. What are peripheral vessels? Vessels or arteries or veins. Lymphatics we are not including. This is arteries or veins. Peripheral arteries and peripheral veins. Veins are needed. Peripheral veins are needed for IV fluids, antibiotics, and the drugs as well. Right. So, but they are also needed for sampling. There are some sampling veins and some are for cannulation veins. Okay, this all will be dealt with. And peripheral artery, how to be safe in getting samples from peripheral artery, important, will be discussed here. I am Dr. Karthik Gengimutu, DM Neonatology from PJ Chandigarh and MRCPCH as well as MRCPCH and having consultant license in London. With my senior colleague Dr. Rajiv, Professor Rajiv, who was ex-professor of neonatology in Amrita Institute of Medical Sciences and currently he is in Dubai for more than a decade. Let's move on to the next slide now. The synopsis of the presentation I already told you. Part 1, Part 2 finished already. Importance of blood administration, need for microcontainers, microanalyzers. The YouTube presentation link is already available on the channel. Part 2, capillary blood sampling, already link is on the channel. Now venous sampling is peripheral veins and arterial blood sampling from peripheral arteries. I will read a simple message: avoid end arteries. End arteries are those arteries which if lost due to any reason, they cannot be, their domain of the supply cannot be compensated by adequate established collateral circulation. So never identify end arteries, avoid them. Next slide. Peripheral venous blood sampling. Timing of blood sampling with IV cannula changes is a simple practical tip to conserve the precious veins in newborns. As you go ahead in licensing status, as a consultant, I do look at the vein count, I do a vein count on the first day and then every subsequent occasion whenever, because veins are precious, they are needed for IV cannulation, even for nutrition. Percutaneous long line insertion is a very essential procedure, life-saving procedure for the baby because it feeds the baby. Especially important for very tiny babies who need to be grown. See, when you want to grow a 500-gram baby, the baby has to at least quadruple in its weight. So the baby has spent 1/4 of his life inside the mother before the baby discharged to the mother, inside the mother, before it has been discharged safely to the mother's lap. We have to have another 3 pots, another 500, second 500, third 500 before the baby can be safely discharged. So it's in our hands, neonatologist's hands. Right. So timing of blood sample is important. Having IV vein count very important. And very small babies, they will not be any visible veins or a sampling compatible or even cannulation compatible veins. Clear? So there are many times where samples are needed because I already told you babies are like this. Babies are cannot express themselves. They are at our complete mercy. Suddenly they are found outside from the protection of the womb of the mother and into our hands. So there are weekly blood samples, sepsis screen, blood gases, liver function test, renal function test, etc. That have a flexibility of maximum a day or more. And once the veins appear, the IV cannulation, IV cannula personally cannot last for more than 2 to 3 days. It's normal. So, but so when IV cannula is due for a change, either because of occlusion, leakage, or signs of early signs of erythema or infection. At that time, when you put in cannula, always think, I am going to put this cannula, there is bloods which are coming. So combine the blood sampling requirements with the cannulation timing. The staff can be instructed to take repeat blood culture and the required lab test at next cannula change and ask for existence of sampling needs. Very important. You say, I already cannulated, you lost a critical case for sampling, you need to poke the baby again. I already told you blood cultures still require a peripheral, a cannula, or central access for taking adequate blood culture. Capillary blood sample is not enough for an acceptable blood culture. And samples for cultures and PCRs should be very clean. And I do a vein count, I said, and stratify and reserve them. You should classify, you should be able to identify which veins are for cannulation, which veins are for long line, percutaneous long line. I'll switch on this slides here. See, percutaneous long line. Percutaneous long lines should be threadable long lines, it's for selling a technique or other techniques compatible, or a peripheral cannula for 2 to 3 days use. A percutaneous long line can be kept as long as 10 days, maximum 14 days. Or a Philby stick, just a sampling, correct? Win stick or Philby stick sampling. So you have to be able to stratify by the cannula diameter and the vein ratio. That's the job of as the neonatologist. So practical guidance videos. I have guidance videos here. Drawing blood samples from children is a hard enough task, and when it comes to neonates, this task has become even more daunting. So know the tricks of the trade. The next clip provides an advice on where the veins are easiest to locate and access. Let's play the video now.
You know, there's 3 complications that make drawing from neonates difficult. One is that they have hard to find veins. 2 is that we have to always stabilize their arms. And even when we conquer those challenges, we still have to obtain adequate volumes.
What about solutions to hard-to-find veins? I like to consider hand veins on neonatals because they're often more developed than their antecubital veins. We also want to make sure that we're using a pediatric tourniquet. And let's make sure we're pre-warming the site because whenever we pre-warm, we're increasing the flow of blood through the area by a function of 7. We can also use wet palpation. Do you know what I mean by wet palpation? If you take your finger and wet it with, say, an alcohol prep, that wetness reduces the surface tension as you're palpating and enhances your ability to feel the curvature and resiliency of the vein because the liquid serves as a lubrication that eliminates the dry skin to dry skin sensation that can mask the feel of the vein. We also want to consider scalp veins. Now, scalp veins are something that's considered an acceptable alternative for neonates, but it does require special training and technique. I've never in my years drawn from a scalp vein, nor would I attempt it. I've simply not been trained. In fact, I've only witnessed it once and it was unsuccessful. But for the record, scalp veins are an acceptable alternative for neonatal venopunctures, but require specialized training.
Of course, we want to recruit an assistant, and to obtain adequate volumes, again, pre-warming is important. And let's also use a syringe so that we can control the negative pressure that's applied to the inside of the vein. So use a syringe with gentle pulling pressure to help obtain adequate volumes of blood in addition to pre-warming. Other solutions when performing a venopuncture is to make sure we have pediatric tubes around for those situations in which we get lesser volumes of blood than we anticipated. And sometimes we might ultimately have to revert to a skin puncture and use microcapillary tubes so that the laboratory can get a full volume of tubes, albeit in lesser quantity. The whole key here is to make sure we submit to the laboratory tubes that are filled to their proper level so that the blood to additive ratio is maintained and not submit underfilled tubes that threaten test results.
Special venous collection techniques are available for tailored to the needs of neonates to avoid needle stick injury. Getting blood samples from the tiniest veins is a task. Previously, in adults, you can use scalp sets or even other type, but in newborn, the small needles they prick and extract blood. To be safe, a wing needle technique in wings and then inserting. That's a flabby stick. So this series of information about special venous collection techniques, winged blood collection system for fragile veins to ensure your safety. You don't suffer needle stick injury. A needle stick injury is a reportable event for the healthcare worker. Procedure to follow: you do a lot of serology. You do the serology for the baby, the mother, and you to avoid and to get consent for all these things. Why you got needle stick, doctor? Why you take due diligence? You should take due diligence. Wear gloves. Prevent needle stick injury. This used to happen many times because of the broken needle technique. The needles used to be broken at the hub, and that used to be the thing. Either you get stuck, hit by this end of this broken needle, or what happens is that the needle is sliced inside and embolished into the baby. Both ways it's wrong. To avoid this, winged blood collection system for the tiny tots came into work. This was in 2000, early 2000s. Many advanced techniques are there for phlebotomists use this for sampling the baby. There is a phlebotomist around in many tertiary NICUs where they take away the workload, the essential workload. Physician orders the blood test. A phlebotomist comes, takes a round, finishes the sampling, thank them. Right. So there are multiple needle sizes and color coding for this NeoSafe for winged blood collection systems. And there are what site of blood collections and procedure of blood collection. These are all explained in the next successive 2 videos. Let's see them. Peripheral arterial sampling. Now, venous sampling, after having done with it, you come to peripheral arterial sampling. Why it's needed? Because many times I told you, in tiny dots, many times we come across occasion where veins are not visible, unusable veins to appear. When the veins appear, takes time. Veins to appear itself takes time. You will not see any veins, very tiny dots, or only lines will be there, not veins, lines. Just the lines will be there. We don't have enough size cannula to cannulate those lines. Still, technology is not advanced. See, you have to get blood. The size of the RBC will be the limiting factor. Size of the RBC, microns, 6 to 8 microns, I'll say. That will be the limiting factor. If that will be the final limiting factor. RBC has to come out of the vein. It is circulating, but it has to come out of the veins through your cannula. So you understand this concept has come. Cannula size to the blood vessel ratio. Cannula size to blood vessel ratio. That will be the limiting factor in cannulation of peripheral veins in those tiny dots. What is cannula lumen size? Cannula external diameter. IV cannula has got internal diameter and it has to have valves. So it's put together, there is a combined diameter and there is a lumen. Through that lumen available, we need to be able to cannulate. That's a stilet. So we have to cannulate, and through this, at least the size, the limiting size will be the size of the blood corpuscles, the WBCs and the RBCs. Which is bigger? WBCs. So, right. So that is important that you remember this vessel size and the cannula size mismatch. Right. So peripheral artery sampling is still important because artery can be stabbed. Blood is in higher pressure, you can still get samples, critical samples especially. So here are the indications for peripheral artery sampling. Continuous blood pressure monitoring in whom NIBP is unreliable or unobtainable. Current gadgets, the blood pressure cuffs, non-invasive blood pressure cuffs are not, they have not been evaluated or quality assessment done for this micropremise. So in them, still invasive beep monitoring is the norm for monitoring blood pressure. Blood pressure monitoring is very crucial because the entire brain function is dependent upon the perfusion. IVH, periventricular malacia, are all related to the dynamics of blood pressure and its variations and fluctuations. Titrating of inotropes, the entire job is to maintain circulation steady, correct pressure, undue fluctuations, please avoid. Right, frequent lab sampling and regular blood gases needed. We are playing almost the role of a god. You're taking over the functions of mother's uterus. There is always complexities which are still yet to be understood in full. Okay, right. Confirmation of certain critical labels like serum potassium. Serum potassium, squeeze sample serum potassium is intracellular ion. It gets released, and then you get a value whether to act or not. So in those situations, when you want to initiate treatment, especially arterial sample for potassium is the gold standard. Potassium standard is arterial sampling. Okay, now contraindications will be infection at the insertion site, inadequate collateral circulation, a failed Allen's test, and lack of expertise or experience. These are procedures which should not be taken easily. Adequately skilled and trained and certified personnel should be doing this. The potential risk could be trauma to the artery, hematoma. Artery will bleed to hematoma, and many times it will happen that arresting the bleeding will be a problem. So you should have common sense and a perfect evaluation of the baby. Thrombosis and peripheral gangrene could happen. The steps for the procedure will be document adequate collateral circulation, avoid end artery punctures. End arteries are the major feeding arteries whose feeding domain cannot be adequately supported by the collaterals. Heparinase saline process and infusion is needed to maintain arterial indwelling arterial lines without complications. And let's say the heparinase arterial line, this concentration can be anywhere between half an unit per ml to 2 units per ml. And excellent, vigilant, expert nursing care is needed to identify complications at the earliest and do appropriate actions. Correct? The videos will be following.
It is very important to establish collateral flow before attempting arterial line placement, particularly when using radial or ulnar cannulation sites. Collateral circulation to the hand can be verified by performing an Allen test, which involves checking the patient's hand for perfusion, while alternately occluding the radial and ulnar arteries. We will now demonstrate how to perform an Allen test. While the patient clenches his or her fist, compress both the radial and ulnar arteries for 30 seconds. If the patient is unable to cooperate, you will have to occlude the arteries for a longer period of time and wait until the palm turns pale. Next, have the patient open his or her fist, and the hand should be pale, meaning circulation has been obstructed. Release pressure on only the radial artery and observe the hand for the return of color, indicating adequate blood flow through that artery. A normal result of an Allen test would be the rapid return of normal pink color to the hand. If the hand does not return to normal color quickly, this indicates abnormal flow through the tested artery. This test is then repeated with the ulnar artery. Instead of visual assessment, blood flow can also be measured using a pulse oximeter, as was explained previously.
So we're going to walk through putting a radial artery catheter in now.
For optimal wrist positioning, place the patient's arm on a board with a roll of gauze pads underneath the dorsal part of the hand to create about a 45-degree angle. This is important in order to provide comfort to the patient as well as good exposure to the radial artery.
We're going to assume, for the sake of this demonstration, that our patient is well anesthetized, and we're not really going to talk about sedation or analgesia for placement of this catheter right now. So I've washed my hands and put on a pair of sterile gloves, and we're now going to prepare the radial artery for arterial cannulation. So what I'm going to do is I'm going to prep the skin here and then drape it with the sterile towels. I'm going to get my ChloraPrep organized, and I'm prepping the skin. And I've left myself a really wide area here so I can see the good part of the arm and the artery, and I'm prepping a nice wide area. And then I'm going to take my towels, and again, I'm going to do this in a way so that I leave myself lots of room. There's no point in trying to do this through a really tiny little hole. And I'm going to use all 4 of these and make a nice little square so I can see what I'm doing.
Point of clarification. Remember, a timeout should be performed prior to any invasive procedure.
So we've got our patient prepped and draped here, and what I'm going to do is I'm going to demonstrate now the method for using the slide-off technique for putting this radial artery catheter. And you can see I have a needle catheter over a needle system here. So this will just slide off. And this is a 22 gauge catheter.
It is important to select the size of the catheter based on the size of the patient. 24 gauge catheters are used for infants, 22 gauge for toddlers, 22 to 20 gauge for small children, and 20 to 18 gauge for larger children and adults.
And remember, as we said earlier, for the technique where we slide the catheter off, we're going to go at a very shallow angle. So I'm going to be at an angle like this, as opposed to an angle like this if I were going to intentionally go through and through the artery. You can imagine how that, in order to be able to thread this off, going at this shallow angle like this, it'll be much more likely that I could thread the catheter off. So what I'm going to do is feel the pulse here and orient myself with the catheter at a relatively flat angle. And then I'm going to be looking for blood return in the top of this catheter. Some people will flush the catheter with saline as a way of enhancing the ability to see a flash of blood. You can see that there's a little flash of blood there in the hub of the catheter. And now what I'm going to do is I've still continue to have flow here, so I ought to be able to thread this catheter off right into the artery, which we've done. And then I have my connector, which I have clamped here, and I also have a little cap on the end of it. And what I'm going to do is I'm going to take the needle out now and hook this up to my connector. And you can see I have the free return of blood there.
So intermittent stabs of peripheral artery is an acceptable alternative when you cannot get a cannula or don't need a cannula. So literally more mature babies, you don't need IBP, correct? You can have an NIBP cup, appropriate size in a baby, say more than 1 kilo. In those, but still it is sampling, we need intermittent stabs of peripheral artery, do it, but still avoid end arteries. Perform collateral supply adequacy test, Allen's test. Puncture the artery with Heparin syringe at an angulation and aspirate the blood once the active location of the needle is confirmed. Cord light source is often helpful in visualization. You can even see the thrombus also. And attempts you do, the clear lumen will be broken and will get bulges. So that's the way you can identify using cord light source. Just a bedside tool with transmission. Also in some slide. Post aspiration of blood for sampling, obtain homeostasis by constant study of glucose. It is always important when you do an arterial puncture that you achieve and document and maintain homeostasis. Correct. So once in a while these complications keep on happening. You should be able to do it. This happened when some inexperienced personnel without knowledge of a superior or a senior person did sampling by the brachial artery. Right, within sort of 12 hours after that, this distal effects, within 12 hours, we observe these distal effects, low perfusion, and when this baby had even a nerve drop, wrist drop like things. I had taken due procedures, follow the due procedure. This base recover. This is see, this was more than a week after. Within 3 days, put the baby under continuous monitoring, removed all the posters, ensured the baby is well perfusion. Applied only hydroid ointment by monitoring, serial monitoring, and there was a line of demarcation which slowly happened. You can see the thumb here. The thumb here. Thumb was also all fingers had the digital blue demarcation line was there. But going by my experience of seeing these cases, this is I think the 5th or 6th case there. This will, babies have enormous potential for recovery. Fetuses. In fact, fetal surgery is a concept which came because healing of scars, cleft palate. Every surgery, scarless surgery needs fetal surgery, correct? So miniature surgeries, scarless surgery is fetus. Fetus has enormous ability to heal, cannot be mimicked outside, correct? So this heals. See the thumb here. Within a matter of days, complete clearance. And this all this clear. I was for fetuses, all these digits. I was following one by one clear. Thumb cleared first, most vascular part. Thumb is most vascular part, radial artery, anastomosis, and it clears fast. Collaterals come and it gets cleared off, and all these demarcation lines they just vanished. And I think little bit of nail loss was there in one finger. This baby recovered completely. Hydroid ointment we applied. There are case reports of successful recovery of this sort of gangrene provided we act earlier. Correct. So take due diligence. Complications will happen. Manage the complications appropriately. Ensure your safety medically, financially as well. Right. So this will complete the part 3 of the presentation of blood sampling in newborn. This was about peripheral blood vessels, which is peripheral veins, and peripheral arteries. Why it's needed, how we should do it, videos were there, and complications. I want that these are things which should not be taken so lightly. Even within the doctors, there are levels of licensing where you have the privileges to do it. Correct? Understand this. A set of tasks. It is lot many years of patience, training, reading to come to this level to manage a baby sub 500 gram or even sub 1 kilo successfully. Please subscribe to my channel, NeoG Heal Thy Babies YouTube channels. And I thank you all for watching part 3 of this video, blood sampling in newborns, an essential skill not to be taken lightly. Right. I am Dr. Karthikeyan Gangamuthu, consultant neonatologist from Dubai. Thank you very much.